Hi, everyone, and welcome to Anaesthesia Coffee Break. I'm Lahiro.
And I'm Stan.
And today we've got a few things going. So we've recently launched the Patreon system. So we'd love to have your support. Click onto the link below. And if you want to support us, please do all of that. So, we really want to create a value for the podcast, but also we realize that we're in a very privileged position. So all funds from that Patreon will be an acknowledgement of the kind of work we're doing for the podcast and for education. But every single cent of that will go towards fund a fellow. And this is funding a fellows training, an anesthesia fellows training in a disadvantaged country or developing country. So that's what we're trying to do.
Fantastic. And we've got our first Patreon. So I think we have to acknowledge her. We have to celebrate this momentous moment. Rebecca, that's it.
It is Rebecca.
Rebecca. So thank you so much, Rebecca. Rebecca just became our first patron. And we have to celebrate this momentous occasion. And as we get bigger and as we start producing merch, as you can see, I've been listening to other YouTube channels and getting myself with the lingo.
I might be shooting myself in the foot here, but the thought of merchandise, I just cringe. I don't want any t-shirts, caps,
cups.
Or what's it? Just a really boring first part physiology topic, something like transducers are life, or
Done. That is a good gimmick.
Symmetry happens. Before I launch into perfusion and diffusion limited gases and how that affects respiratory physiology, why don't we launch into our first performance tip? So Stan, what do you have for us?
So this performance tip I have is really about teamwork and about supporting the others around you to create your own success. And my reflection was on one of the best moments of the Olympic Games, and this was towards the end, and I'm sure everyone has seen it in the news. It was the decathlon, and Ash Maloney was coming in third place. And so we're heading into the last race. It's the 1500 meters. And it's well known that this is not Ash's strongest race. And so he just needed to perform at a certain level. Otherwise, the fourth and fifth place, if they had won, they could have gone to third place and win the bronze. Mm-hmm. So his teammate, Cedric Dubler, who had no chance of winning at all, but was a much stronger 1500 meter runner, what he did was he actually paced Ashley all the way through. And there was an iconic photo, or in fact, iconic video that everyone knows about, towards about the 300 meter mark. You could see Cedric just getting into Ash's ear, just telling him just to go for it, to put all his effort into the last couple of 1 to 200 meters. And, from that moment, you could see that inspiration that Cedric sort of gave Ash and really pushed him to the finish line. And I think, when I look at that and I think about not just for our lives, but also, for our trainees in study groups, I think it's so emblematic of how we should look after one another and how we should support those around us. And words of encouragement really creates success around others, and it really creates success for us too. So that was like the key message that I got out of that. It's really one of the touching, iconic moments.
I just love that. Like this is such an important point, and I love that you get all of these things from following sport, which is really incredible. And there's such great examples, because I think in sport is one of the realms where it really is a zero-sum game. Someone is first, second, and third, and so there's this massive competitive elements. This person really was, in a sense, sacrificing their performance for someone else, and that's beautiful to see. But the good thing is that, like, I think in the anesthetic world and doing this exam, it's not a zero-sum game. You don't lose by helping someone else. You can only win, if you're trying to help someone who doesn't understand physics and measurement as well as you do. By teaching it, you're learning it better, they're learning it better, and then you foster this good spirit and this good community between you and your study mates, so that they'll help you on the stuff that you're not so great at as well. And then hopefully you pass together and you celebrate together and you form these relationships that you'll, just have for the rest of your life.
Exactly. 100%. The relationships that you get out of this exam, they're with you for life. And, you form a bond with that person, with the people you study with, because it's, the blood, sweat, and tears that of 1 year, almost 1 year of your life, that holds you together. So yeah, I agree. There's competition, which is really good. It really strives you to be better, but there's also that spirit of competition where you help one another, and it just improves everyone as a group.
So how do you inspire this kind of community or friendly competitive spirit? Like, what are some actions that you could take to try and foster that?
The big thing for me is about engagement. It's about reaching out and making that step of inclusion. So in other words, when Cedric was running, he didn't have to shout into Ash's ear. He didn't have to go out and paste Ash. This was all done from his own initiative. And I think, for this part one exam, things that we can sort of look at is, the sharing of resources, the sharing of our time. So different people will be at different hospitals, and there are opportunities that occur at different hospitals. And having that ability to get those resources and say, hey, someone has, offered a tutorial on this topic here, or someone has offered to do a Viva or practice exam. I'm gonna see whether I can get them to come in, get you involved as well, and we can all do it together. And those are sort of the things that are emblematic of really a good, supportive study group.
Yeah, I remember within our study group we had someone who's really good at timetabling. So I just didn't know. I had so much inertia about getting a study plan, but someone else sorted that out. Another person was really great at teaching and just kind of simplifying things. So I'd often run the short answer questions by that person and go, what do you think is important about this? Because they're able to just somehow, get the crux of that short answer question. Whereas I'm trying to focus on a whole bunch of detail. Like, I feel like genuinely everyone has a place and a strength, no matter how small it might seem, which, you will bring value to the group, whatever it is, and be able to share a lot of these things.
You're spot on. Everyone's got their strengths, and it's about utilizing that strength and creating that group harmony. So you're always gonna, I think it's very natural. I think within the group, you're gonna go, Lahiru, he's absolutely brilliant. He just understands these concepts. But what you can bring is just that sense of team bonding, that unity. It's as simple as maybe, I don't know, as you said, just creating an organization, creating a timetable, creating opportunities for others.
Yeah, no, that's really good. Now, I was thinking, even the kind of things that I guess most of us do, like imagine all the times you've taught someone. So, we obviously do a lot of teaching, and I think we just really enjoy teaching. It's kind of the thing we like to do. So we do a lot of teaching, and it's amazing that even, 10 years down the track, people will remember some of the shoots that we gave, or the lessons that we gave, or the mnemonics we taught them. And that gives me a little buzz every time. This is just us doing something that we enjoy. Maybe we did a shoot on, perioperative medicine or whatever, and someone goes, yeah, remember that mnemonic, every anesthetist really loves morning coffee? Yeah, I still use that. And it gives you a little buzz that someone remembers, or I remember lots of other mnemonics or helpful study hints from other people, and go, oh yeah, you taught me that. Awesome. Thanks so much.
Morning. It's time to copyright it, La. And what is his morning coffee? Just quickly.
So the preoperative cardiovascular evaluation guidelines from the ACCHA. So
always willing to learn. So we'll quickly go through this, and this is just for my benefit. It's not for anyone's benefit outside on listening on this podcast. It's just for my benefit. And then once we've done that, we'll go through the question. Okay.
Yeah. Okay. Here we go. So how it's a pretty messy flowchart in the 2014 guidelines. There's a whole lot of things going, but essentially it's emergency, active cardiac condition or acute coronary syndrome.
Yes.
Low risk operation, metabolic equivalence, and then will testing change further management. So emergency elective is every,
Yes.
Acute coronary syndrome active cardiac condition is anaesthesia. Every anaesthetist
Yes.
loves. So that's, is it low risk?
Yes.
L, loves. And then M is METs, morning. And then will it change management or consider testing change management is C, coffee. And
Wow.
it's
Nice.
just, this is something I think about every day, really, because every time I get a case, I'm like, oh, is this for testing or is it not for testing? Is it low risk and they're not having a active cardiac condition? Therefore, that's fine. They can proceed with their cataract, even though they've got NYHA3, heart failure, and severe OSA and whatever else. And I find it really
What a great mnemonic.
Cheers. Thanks, Dan.
Last mnemonic. Okay.
Yeah. It's one of those times that, most of my mnemonics are terrible. They're just a bunch of letters together. But this one actually made sense. It's every anaesthetist does love morning coffee. It's true.
I still remember Paint BC from your renal talk. So
that makes one of us. Okay.
All right. So let's go ahead with discussion about perfusion and diffusion limitation. So this was a question in 2003.
Mm-hmm.
And the question is, explain the difference between perfusion limitation and diffusion limitation in the transfer of gases between alveolus and the pulmonary capillary. Outline the factors that determine whether gas transfer is perfusion or diffusion limited. Great. So what is perfusion limited and what is diffusion limited?
Yeah, so I found that these definitions could get unnecessarily tricky and, you can end up using a lot of words trying to get it across. So I tried to make it the most brief definition possible. So for perfusion limited, I said it's just blood flow in the capillary determines the rate of transfer of gas. Blood flow in the capillary determines the rate of transfer of gas. And then for diffusion limited, I would probably do something like, it's described by Fick's law, where flow is proportional to area over thickness multiplied by D, which is solubility over the square root of molecular weight, multiplied by the pressure difference, or P1, P2, or P1 take away P2. And it's where so diffusion limitation is where the transfer is dependent on the properties of the gas and those of the diffusion barrier. So blood flow in the capillary does not determine the rate of transfer of gas. And so that I try to just get as simple a definition as possible, even though it can be a bit of a complex kind of topic.
Well, I think you're right in terms of it can get quite complex, and I like what you've done in terms of just simplify it, and in terms of just using the words itself to help actually prompt you in terms of what the definition is. So, as you sort of said, with perfusion, you think about blood, and with limited, you think about what limits it. So, it's the blood flow that limits the amount of uptake of the gas, and same with diffusion. So, I think that's really clever in terms of what you've done with the definitions. What's Fick's law?
Yeah, I mean, so Fick's law is just one of those laws that, I think you'll invoke Fick's law and Hagen-Purcell equation and a few others constantly throughout your, first part learning and your SAQ practice. But Fick's law, I mean, it really will. This is how we can, I guess, frame this question. So basically, what are the factors that determine whether a gas will be perfusion or diffusion limited? You can pretty much talk through Fick's law, and that could be your mnemonic right there. If you can sort out the parts of that, you can probably talk through this reasonably well. The next part of my answer will probably go into talking about specific gases, because then it gives it some clinical relevance. So, what's Fick's law? It's area over, rate of flow is proportional to area over thickness. And so that's really talking about, the alveolus area, the, pulmonary capillary to the alveolus interface. And that's, really large in the lungs. It's 50 to 100 square meters, or is it the size of a tennis court or something like that? And the thickness is very small. So was it 0.3 micrometers or something, very thin. It really allows for transfer to happen very quickly. So area over thickness times solubility over the square root of molecular weight, and the molecular weight will change depending on the gas. But the solubility does change remarkably, as does the pressure differentials, depending on what we're talking about. So let's just, talk through those factors. I mean, solubility, if it's got low solubility, it's slow transfer across the membrane, and often that will make it perfusion limited. But if it's high solubility, you might have rapid transfer, and it can be perfusion limited if it's got a high rate of equilibration, but it might also cause diffusion limitation, even if it's high solubility, if there's a very slow rate of equilibration. So I'm thinking nitrous has high solubility, it rapidly passes through the membrane, and it has a high rate of equilibration, so it's perfusion limited. But carbon monoxide, it also rapidly transfers, but then it binds very tightly with hemoglobin, so it doesn't really get to that equilibration state, and so it's diffusion limited.
Mm-hmm. And I really want to highlight the fact that you said equilibration, and I think that will actually help a lot of trainees actually understand whether a gas is perfusion or diffusion limited. So as Lars said, and I'll sort of repeat it again, for gases that are perfusion limited, the gas in the alveolus will reach equilibrium with the gas in the pulmonary capillary. And then for gases that are diffusion limited, you actually don't get equilibration. So in other words, the gas in the alveolar is always more than the gas in the pulmonary capillary. So I really like that. I really like the fact that you focused on equilibration, and I think that will give trainees a clue in terms of whether a gas is perfusion or diffusion limited, especially when you think about the changes that oxygen can happen between the two.
Yeah, great. I like that. And so then we can talk about the properties of the blood gas membrane. That's really, the fact that thickening of a membrane can slow diffusion of oxygen and can change oxygen from being perfusion limited to diffusion limited. So think of any thickening of the alveolar membrane, and that will change the ability of oxygen to diffuse. So now you can go from a good state, which is perfusion limited, that's the normal state, to diffusion limited, which is abnormal. The next one, this is what we were just referred to briefly before. How much gas is bound to other things in the blood, like hemoglobin? So for example, we mentioned that carbon monoxide, there's many ways that carbon monoxide becomes toxic, but one of those ways is tightly binds to hemoglobin. And so the rate of equilibration of the partial pressure is really, really slow. Nitrous is minimally bound, and so it gets to that equilibration state much quicker, and it's perfusion limited. So the next part, the final part of that you can mention in the fixed law of diffusion equation is a partial pressure gradient, or the driving pressure. And this makes a lot of obvious sense. If there's a large pressure difference, then you will have, faster diffusion across the barrier. But say you have a situation of altitude. So suddenly at altitude, now your oxygen partial pressure in your alveolus is a lot lower. So potentially it's 50 millimeters mercury and down. And, in the venous system, it might be 20. Therefore, now diffusion occurs far slower and oxygen may become diffusion limited. The final thing to mention then is the transit time to blood. So that's obviously not in fixed law of diffusion, but something you need to mention, because normal transit time is really quick. So it's, the transit time of a red blood cell through that pulmonary capillary is, 3/4 of a second, 0.75 seconds. And this can be decreased in exercise. So, it can be decreased by, it's 2/3 really. So now it can be, 1/4 of a second or 0.25 seconds. And as oxygen is normally fully equilibrated, when that red blood cell has traveled 1/3 of the way along the capillary, it's not usually perfusion. It doesn't usually become diffusion limited just with exercise, but imagine there's something else going on. And then if you combine any of these other factors together, suddenly a perfusion limited gas like oxygen can become diffusion limited. If you combine exercise with altitude, or exercise with thickening of the blood gas membrane, or some change in the partial pressure drive, things can change from perfusion, which is a good state for oxygen, to diffusion limited.
The fact to point out is that this is really specific to oxygen, and because its diffusion is also not just dependent on its solubility in blood, but also with its solubility through its reaction with hemoglobin. So it has to react with hemoglobin, and the time that it takes is going to be within that sort of, as you said, that capillary transit time. So if that is reduced for any reason, and especially with a lower partial pressure, that's going to change oxygen from perfusion to diffusion limited.
Excellent.
All right. So what are some examples? And this will really help with trainees sort of understand this further.
Yeah, that's right. So fortunately, as you talk through all those principles above, you can probably put in some of these examples as you talk through. But if I've got extra time in this SAQ to just, really state clearly what each gas is, perfusion or diffusion limited, I think that's always an advantage. So what are some examples? Carbon monoxide, it's diffusion limited. It tightly binds that hemoglobin. So there's very, little rise in partial pressure. And so there really isn't any time to reach equilibration. So it is diffusion limited. Then we have nitrous oxide, as we mentioned before. It's very, very soluble, rapidly equilibrates across the blood, into the blood. And, that pressure equilibrates very quickly. So it is perfusion limited. So apparently it's about a tenth of the way along the capillary. So oxygen, a third of the way. Nitrous oxide, a tenth of the way along the capillary. So it equilibrates very quickly. And again, that is perfusion limited. You have oxygen, which is also perfusion limited, and it lies somewhere between carbon monoxide and nitrous. And it's, only takes a third of the way to become equilibrated. It is reasonably fast, reasonably rapidly soluble. But again, it can become diffusion limited with other problems, like we mentioned, disease, altitude, increases the diffusion barrier and lack of that partial pressure gradient.
So there's one more gas that trainees often bring up, and it's from a question, I think, in the 1990s. And the question relates to CO2 and whether the gas CO2 is either perfusion or diffusion limited. And initially, whenever I saw the question, I thought maybe this was an error. Maybe they meant carbon monoxide. But I really do think that reading the examiner's report, they actually do mean carbon dioxide. So what are your thoughts on that? Because I've got my thoughts, and I spent an unnecessary long time thinking about this. But I want to hear your thoughts, and then I'll put my sort of 2 cents in.
I'd expect no less, and I hope that I hope that we don't contradict each other too much. But
I think we might.
I mean, the first thing is that perfusion and diffusion limitation really refers to gases as they're moving in to the bloodstream, not really out. So it's already a bit weird. Like, I'm not a respiratory physiologist, but I believe that by talking about carbon dioxide, you're really outside the definitions that we've normally talked about. That said, if you could somehow be a bit tricky with your language and you can use the same principles but just reverse them, you'd still talk about area and thickness. You think about the solubility of this gas. It's 20 times more soluble than oxygen. And then its association with compounds that, may or may not, cause that partial pressure gradient to increase or decrease. Because, as we know, CO2 is highly, bound, or carried in the blood, not just as diffuse, in its diffused state, but also as carbamino compounds and bicarb. So when you look at a graph of the, of CO2 equilibrating across the capillary, it looks slightly. So I'm just going to look at the graph now, and it probably equilibrates about a third of the way across the pulmonary capillary. So similar to oxygen. So if you were to extrapolate that, you could call it perfusion limited in its ability to diffuse the other way across the barrier from capillary into the alveolus. But again, similar things would apply. If you've got a change in disease states and potentially exercise causing faster transit of that red blood cell, maybe this could become diffusion limited. What are your thoughts, Dan? Are we going to disagree?
So, actually, listening to you now, yeah, I think you've actually touched on a lot of the major points which cause a bit of contention. And the first thing, as you sort of pointed out, is that carbon dioxide is exhaled and not inhaled. And then the other thing that you pointed out, which I also really like, is that if you actually look at the equilibration, so the equilibration of the pulmonary capillary gas does often equilibrate with the gas inside the alveolus. Because remember, in the Bohr equation, we do substitute using Enkhoff's modification, arterial CO2 for alveolar CO2. So immediately there's that assumption that they equilibrate. So we know that from what we talked about before, that with regards to the equilibration of gases, if you get equilibration of gases, you will often describe it as perfusion limited. Whereas if there is a difference between the alveolar gas and the pulmonary capillary gas, you can say it's diffusion limited. Now, the thing that makes it complex is the rate of transfer, okay? So we know that the rate of transfer is not just diffusion, it's not just diffusion or perfusion limited, it's also ventilation limited. In other words, if you were to increase your ventilation, the amount of transfer of CO2 that you can achieve will actually increase. So
and that's literally changing your partial pressure gradient, the driving force.
Yeah, that's right. And sort of pushing it out. And so that's just the idea that I sort of came about in terms of that CO2 it's not just perfusion or diffusion limited, it's actually ventilation limited. And there's actually a lot of complexity involved as well, because if in the initial phase that you don't get enough ventilation, then you sort of mentioned it as well in terms of there's also the buffering of CO2. Then you also get compensation and correction of CO2, because remember that CO2 is a metabolic gas. It's being produced, but it's also being buffered, compensated, and corrected as well. So there's a lot of forces that are interplay. And lastly, in your point, in terms of the diffusion impairment, you're right. Because CO2 is 20 times more soluble, it's only with very, very severe disease that you would see diffusion impairment affect CO2 diffusion. And that has to be very, very severe disease. Otherwise, the most likely cause of a difference between the pulmonary capillary gas CO2 and the alveolar gas CO2 is going to be dead space or hypoventilation. Yep. But otherwise, yeah, I think you really touched on the key concepts, and I actually I agree with it.
Good. And I like that you've gone down that rabbit hole, and I can imagine you maybe spend a few hours to synthesize this information, and hopefully
maybe a few days, but
few days, yeah.
Don't mention how much time I
that's right.
have thought about this concept.
That means that hopefully the listener doesn't have to go down that rabbit hole, because Dr. Stan here has come and look down it. And
yeah, look. There's only one textbook which touches on it, and it's West. But West, he himself is like, there's only like about 4 or 5 lines from memory about this. So there's actually not enough to write a page on whether CO2 is perfusion or diffusion limited. But certainly, I think if you put those key concepts in terms of how the pulmonary capillary gas equals the pulmonary alveolar gas, you could make the argument that CO2 is perfusion limited rather than diffusion limited, except in very, very severe diseases. If we were to get more clinical, how do we measure diffusing capacity?
Yeah, good. So as I was going through this for my respiratory lectures, I thought, this is the way, you say you're absolutely smashing this Viva, or, doing really well in the short answer and have, the ability to write a lot. This would be something else that they could ask you that's quite practical. It's clinically relevant. And it's also something that we just see constantly on, lung function tests. But until, I studied respiratory physiology, I didn't think too much about it. So, what's the definition of diffusing capacity? It's actually this, this term DL, and DL is just rearranging that fixed law of diffusion. So if you remember, the diffusion, or the volume of the gas transfer, is proportional to area on thickness times solubility over the square root of molecular weight. Those things aren't that easy to measure, especially area and thickness. So, the lung is very complex. It's very hard to measure those components. So why not just use that as your, the thing that you're trying to measure? So if you rearrange the equation, you can just put A over T times D to one side. And now you have DL equals A on T, area on thickness, times solubility over molecular weight. And that equals the volume of gas transferred over the pressure difference. And that's diffusing capacity. And that's the term that you'll see constantly on your lung function tests. And as we mentioned before, and Stan was alluding to before, it gets really interesting, because how are we possibly going to measure this? And they realized back in the day that it's very difficult to measure with oxygen, because you need to measure through assumptions and averages what your pulmonary capillary oxygenation is. So it's really difficult to measure this with oxygen, because you can't measure accurately the back pressure, or the pressure gradient with oxygen. But we do have a gas that you can do this with, because carbon monoxide has very, very low partial pressure in blood, because it combines so readily and with such high affinity to hemoglobin that you could literally just use the partial pressure of alveolar carbon monoxide, and you wouldn't need to get the capillary carbon monoxide pressure. So how do you measure this? So you want to get the volume of carbon monoxide transferred and then you want to know its pressure. And literally dividing those two will give you DL, or diffusing capacity. Now, we won't need to really go through a lot of the ways you can do it. I think there's a couple of methods. The single breath method is the one that I wanted to know from my exam. A single inspiration of a dilute mixture of carbon monoxide, 0.3%, and then you measure the rate of disappearance from alveolar gas during a 10-second breath hold. And then you measure the inspiratory and expiratory concentration of carbon monoxide with an infrared analyzer. And then you might also need to measure helium, use helium to measure lung volumes. And then you get this normal value of about 25 mils per minute per millimeter mercury. And that's what you're looking at as your normal diffusion capacity.
No, great. And so how does DLCO changes with some other physiological conditions?
Yeah, so imagine if you get any kind of problem with your area, the barrier, the diffusion barrier, then you'll get a decrease in your diffusing capacity, but also just through exercise, you'll actually get an increase. And so with exercise, you get an increase of about 2 to 3 times this diffusing capacity, because now you've got recruitment and distension of pulmonary capillaries. And that would aid in that diffusion across the membrane.
So going on from the idea that with exercise, there's an increase in cardiac output, which increases your diffusing capacity. It also happens in patients with obesity. So obese patients have high cardiac output states. And then you actually see an erroneously high DLCO in these patients. And then the other scenario that you'll see a thing called DLCO corrected. And this is what you were talking about before, with the idea that hemoglobin actually affects solubility. So what DLCO corrected does is that it corrects it for hemoglobin. Otherwise, in patients with anemia, you'll actually see DLCO reduced. And in patients with polycythemia, you'll actually see your DLCO normal. So what happens is that with patients with hypoxic respiratory disease, with, let's say, severe diffusion impairment, one of the mechanisms that the body sort of responds to that is through polycythemia, is through increasing your red blood cells in order to increase O2 carriage. And
that would be in like every patient with COPD you have doing the lung function tests. They would look normal because they've often got,
because of their high hemoglobin, you know, and so what the test does is that it corrects it for the high hemoglobin and actually shows that there is pathology there.
Excellent. I think we can probably wrap it up there. So, I mean, in summary, diffusion versus perfusion limitation, I just structured that with a definition as quickly as I could get it out, because I don't want to be too complex in defining these things. I want to be able to remember it in the heat of the moment in the exam. I'll then work through fixed law of diffusion to then try to address each of those factors, mentioning how we would make something diffusion or perfusion limited, also mentioning transit time through the alveolus, and then finally just going through each of the gases, carbon monoxide, nitrous oxide, oxygen, and maybe even carbon dioxide. And then we just went through diffusion capacity and how we measure that and what are the concepts there and how it's affected. So I think that's a pretty good summary and probably, about all we need to talk about. So thank you very much, everyone, for listening. Again, please share and subscribe. And if you'd like to support us at our Patreon, it's just in the link below. Thanks very much for listening, and we'll see you again next time.